Hi, how's everybody doing? Thank you all so much for being here on a Monday evening. Just a few things before we get started. My name is Ivan Davila, and I am the Director of Communications and Community Engagement here at Central Health. And we've got a full agenda ahead of us. Before we get started, just real quick, if you need to step out to use the restroom, please feel free to do so through those doors over there. And the restrooms are right on this side. As you just take a right, and they'll be on your left-hand side. There is also some snacks and beverages, so feel free to just get up and help yourself throughout the program. And ¿hay alguien que necesite traducción al español? ¿Alguien que necesite traducción al español? Si alguien necesita traducción al español, aquí tenemos traductores atrás. Okay. A couple of things before we get started. I wanted to just call out a couple or a few people just to see what we expect to get out of tonight's meeting. Can somebody tell me, just off the top of your head, what are you expecting to get out of this evening's meeting? Somebody?
No.
Mr. Gordon? Morden.
We adjourned in September with some goals that Sendero had to meet in order to continue. And so we want to see if they're making progress and how terrified we should be, and if we have to be worried to find out any action we can take between now and summer.
Great. Okay, we're writing this stuff down behind us. So just Sendero's progress. Somebody else? What do we expect to get out of this evening's meeting? Somebody else? All right, well, thankfully, we're going to be covering all of that extensively this evening. Without further ado, I'm going to introduce the Vice President of Communications of Central Health, Ted Burton, who is going to introduce the panelists.
Good evening, everybody. First, I want to show the agenda for tonight so you know what's coming. You also have a printed copy of this on your chair. We're going to start with a very brief 2-minute video that explains Central Health and the Central Health Enterprise. Then we'll have a panel presentation, and I'll introduce the panelists in just a moment. And followed by the panel presentation, which should probably take about 10 or 15 minutes, we're going to open it up for questions. So with that, let's start with a quick overview of Central Health and the Central Health Enterprise.
Central Health is the public agency that ensures Travis County residents with low income have access to the best possible health care. We do this by working with a network of partners, including Community Care, Sendero, and the Community Care Collaborative, Central Health's nonprofit partnership with Seton. These partners make up the Central Health Enterprise. In 2016, Central Health funded care for about 1 out of 10 Travis County residents, nearly 144,000 people. 96% of Central Health's budget goes to healthcare delivery. Central Health is creating a coordinated healthcare system that provides access to care in new and innovative ways, from community-based clinics and a new state-of-the-art teaching hospital to mobile and virtual healthcare. The Central Health Enterprise nurtures a healthy community by providing better outcomes for patients, not just paying for more doctor visits. How do we do it? Central Health funds Community Care Health Centers, the largest network of clinics in Travis County devoted to caring for people with low income. Central Health also partners with Seton through the Community Care Collaborative to share resources and provide high-quality, cost-effective care for residents with low income in hospital and clinical settings, creating a true safety net of care. Central Health's Medical Access Program, or MAP, helps Travis County's lowest income residents get health care. With MAP, doctor and hospital visits and prescriptions are covered. And through Sendero, Central Health's nonprofit health insurance plan, about 75,000 people have received health coverage since 2014. Through these collaborative partnerships, Central Health is delivering on its promise to Travis County taxpayers to reinvent healthcare by increasing access to quality care, reducing costs, and creating a model healthy community. To learn more about how we're transforming healthcare in Travis County, visit centralhealth.net. Also follow us on social media.
Since we produced that video, we got our 2018 annual report, and the numbers actually increased. Last year, we provided care for 1 in 7 Travis County residents. Now I'd like to introduce our panel, and I'll start from next to me is Dr. Guadalupe Zamora, our board chair for Central Health. Michelle Tiadina, and she is, I always get your title wrong, Michelle's, Director of Health Insurance Enrollment and Training. Central Health CEO and President Mike Giesland. Over here on the other side to your left is Kit Abney-Spels, our Senior Director of Eligibility Services. Wes Dorkowski, the Sendero President and CEO. One of our board members is Dr. Charles Bell, who also serves on the Sendero board. And then we have with us tonight 2 other board members in the front row, Maram Musaitif, who is a Central Health board member, and Shannon Jones, who is a Central Health board member. So would you please help me welcome everybody here? And with that, I'm going to turn it over to Mike Giesland, Central Health President, CEO.
So I want to thank you all for coming here this evening and taking time out of your schedules to hear about Sendero. Before I go over, start the slides presentation, if we could back up a slide, or did I advance it by accident? We're doing this because we want you to know what we know. We want you to know what we know in terms of how Sendero is doing. It's still early in the year. We also want you to know what the time frame is. In other words, what to expect as the year comes up, sir, as you've pointed out. And I think this is important for a couple of reasons. Insurance is complicated, and you have to be able to connect with people, whether they consider themselves policyholders or they're patient advocates or they're interested community persons that just want to know what's happening with a community-based health plan. Regardless of how you see yourself is how we want you here tonight. And we hope that we speak to you, and to the extent that we don't answer all of your questions or can, either because it's too soon, we don't have the data, or because we need to go research the answer, either way, we want to be fully transparent, and we'll work to get you the answers to your questions. So with that, I want to talk a little bit about how Sendero fits in with the Central Health enterprise. And here's Central Health. Over here to my far right, Community Care is our primary care partner, if you will. They're the largest federally qualified health center here in Texas, and they see approximately 80% of our patient population. We also have other relationships, which I'll cover here in a second. Sendero is a nonprofit, community-based HMO, and this is a means, as you all know, whether you're policyholders or not, of how we help finance people's care. But it goes just beyond the dollars. It goes just beyond taking premiums and then converting that into an insurance policy. It's also about a level of service and touch that you really don't get in larger insurance companies. And Wes, I'll let him brag on, he's got staff here that make that happen day in and day out, and we're really appreciative of what you all do to try to connect people with care in a way that goes beyond just a referral to a doctor. And then we have the Community Care Collaborative over here. This piece of the Central Health enterprise is important because this is where a lot of our this is where all of our primary and specialty care contracts rest. So for example, I see People's Community Clinic here, Regina. We have a partnership through the CCC, which is funded in part by Central Health and Ascension Seton to help bring additional primary and specialty care resources to Travis County. So think of this as a way to be able to bring together multiple numbers of providers to be able to provide a strong safety net of care. So that's Central Health in a nutshell in terms of how it all fits together. But again, I'm happy to talk more about this at length. Yeah. Sorry, I'm not a very good stage manager.
But take your time. Hey, no, that's fine. Thanks very much. So I will keep my comments brief and stick to the slides. And thanks everybody for coming. We're looking forward to this, and we'll try to do this more regularly. So feel free to have at it. Wait for the questions, but at that point, have at it. So as everybody, I think, hopefully knows, Sendero Health Plans, I've been here since 2011. First coverage in spring of 2012. So what does that make that? 7 years? 9 years? 8 years? Oh, sorry. Yeah, I was going to end up there. Little accident. Well, that's okay. I got good coverage. So the health plans was set up to offer coverage in the surrounding area. The whole idea is that we can pool risk to offer quality, affordable coverage, and kind of in support of Central Health's mission. And it's an important idea. You know, for an insurance company, you just can't cover 10 people. The more people you cover, the better. And by doing so, hopefully we can help Central Health's mission of providing more care for the community, especially for those who need it most, lower income. So I think, as hopefully you remember, right now we're mostly focused on the Affordable Care Act. The Affordable Care Act is attractive for a number of reasons. It offers a defined set of benefits and guaranteed coverage, no matter what your conditions. From the business side of the house, it offers 2 sets of subsidies, which help make sure this can be done. One set of subsidies focused on lower income people, which is important. Central Health is directly leveraging that through one program. And additionally, it offers a second set of subsidies based on morbidity, so that those sickest people who have been guaranteed coverage, you know, so that we as a payer can make sure we cover those people. So it is that second one that we've been trying to focus on more efficiently for the benefit of Central Health and the community. If we want to go to the next slide, is this one my slide too? Is that okay?
So since the inception, the creation of Sendero, we've invested over $108 million. This last calendar year, was a sum total of $36 million. And I get a lot of questions as why. Well, whether you're talking about Sendero or any other health insurance plan that's in the ACA today, and I don't care which state you go to, there's a lot of volatility and a lot of almost near impossible market conditions that you have to overcome in order to be able to write insurance in the Affordable Care Act marketplace. And so this is not unique to Sendero. There's a lot of insurance companies, you don't read about it as often, but there's a lot of insurance companies that have had to capitalize their insurance plans significantly to be able to withstand the volatility in the Affordable Care Act marketplace. And so that's why when you see that line, how it spikes, what happens is that when companies have less sick or healthier populations, they pay into a risk pool. If you have populations with severe and chronic conditions and you have a certain number, then you get paid by the risk pool. And that's a feature of the ACA. And so what happened there in those years where you see that spike is you had a significant pay into the risk pool by Sendero. And being a community-based health plan and unable to go to Wall Street and raise capital, or writing in multiple states where you could go raise capital, then you have to go to your sole capital source, which in this case is Central Health, to be able to come up with the necessary funds. So sum it up just to say it's a rough market out there, and it takes capital to be able to get through it. In terms of the services delivered, and this is that $475 million, is that claim or claims paid? So that is a claims paid number. So the way to think of it is that for the $108 million that we've put in, it's not just $108 million that goes into a company and those funds go to an investment banker somewhere, or they pay stockholder dividends. This is a community-based health plan, and so we've been able to cover the health care to the tune of $475 million.
I was going to say, that is an important point. So we are a commercial insurance company, so the difference from Central Health is that when we provide care, it's on a commercial market. So the providers are getting paid fairly. You know, there's a flow of funds that...
You want to make sure you're on the mic.
Oh, sorry.
We are
Okay,
sure.
I don't want to stray too far, but it was an important point that $475 million goes back to the providers in the healthcare system that we all use. So instead of a lot of uninsured people, you know, for charity care, the charity care system is a great thing. It requires a lot of people to donate their services. When somebody's covered on Sendero, your provider gets paid fully. This helps strengthen the insurance, you know, it strengthens the local healthcare system for everybody that loses it. You know, so by ensuring that there's a strong base, we've kind of improved it for everybody, and that 475 is part of that.
So local enrollment for 2019 in our region showed that 83,824 residents enrolled in a qualified health plan offered through the health insurance marketplace. Sendero's enrollment was over 14,000 members strong. Now, although this is an 8% decrease from last year, we did anticipate that for a few reasons. So we did have another shortened enrollment period of only 45 days. So consumers had 45 days to enroll in a health plan for 2019. Now, without a qualifying event, that's the only time of the year that they can enroll. We also had the penalty for the individual mandate was reduced to 0. So although it's still the law, there will not be a monetary penalty applied to consumers. Then we had the rollout of what we call short-term plans that were offered outside of the health insurance marketplace, again with minimal coverage, but some people opted to buy into those short-term plans. Now, on a positive note, due to a stronger economy, we did see an increase of employment, which resulted in more people being offered employer coverage. So that was great news.
So before I get into this next slide, I want to check in with you. Somebody throw out some key terms or what your understanding is at this point of what you heard. Somebody hazard a guess as to what's registering right now. I just want to see where we are. Bill, if you make eye contact with me one more time, I'm going to call on you. Yeah.
Lots of return for the investment.
So there's a return on the investment that's measured in terms of people's care. Okay. All right. Yes, sir.
I want to make sure you might use it. Thank you so much.
There's a number that wasn't there, and I don't know if it's measurable. When you get a bill for the hospital and the hospital says, we're charging you $3,000, and then the contractual adjustment takes it down to $1,500, and then your insurer pays a fraction of that $1,500. Do we have any idea what's the volume of contractual adjustments for people who are covered under Sendero? Because that's a big part of why it's helpful to us.
Right. I think, Wes, you know, when we get to the Q&A, let's just put that one in the first of the line. But I think that's a good point. In other words, if you didn't have insurance, what would you have had to have paid? Okay. All right. Thank you. So, what about 2019? As you've heard from Michelle, there was a change in the Affordable Care Act marketplace in that you saw reduced enrollment statewide. So as the trend went with the market, so it went with Sendero. So you saw a drop in enrollments. And the Sendero management team and the central health management teams, we got together, and I think there was an understanding. We expected enrollments to drop somewhat heading into this year. And so there needed to be a strategy to stabilize Sendero. One way to do this, and I mentioned it on the slide before last, is that there is additional federal funds that you can draw down through the Affordable Care Act. And the way to do that is if you have individuals that have more chronic or more severe conditions, you draw down more federal funds. Again, goes back to the premise that those that have healthier populations tend to pay in, those that don't tend to be paid by the fund. And we knew that with the medical access program, we had a number of individuals that had severe enough health conditions that they would benefit from a Sendero health insurance plan. And so the Board of Managers at Central Health, they allocated up to $6 million in premium assistance funds to be able to cover the premiums for those individuals. Because right now, if you buy on the Affordable Care Act marketplace and you're not part of a premium assistance program, you're going to dig into your pocket and pull out your car keys. You're going to dig into your pocket and have to put down money to pay premiums, right? Well, for those individuals that are on the medical access program, you're talking about people that are 200% of federal poverty level or less. In fact, a lot less than 200% of federal poverty level. They currently don't pay their premiums. And so if you're going to take them out of one health program and put them over here in another, they don't have the means to pay the premiums. And so what the Central Health Board did was they set aside $6 million to be able to cover those premiums. We estimate that we're going to spend about $3.6 million in premiums, give or take. But it was also important and imperative to the Board of Managers that individuals be given a choice. No one was going to be forced to move if they didn't want to move. And some chose not to. Some said, you know, I have the medical access program, I know it, I understand it. I've heard about insurance, it's complicated, I don't want to deal with it, and that's okay, that was their choice. And so through this, and you'll see a little bit about what all was involved in the, when I turn it over to Kit, but that was more or less the strategy for 2019. Let's go to our medical access members, offer to pay their premiums, and give them the option to control how they wanted to finance their health care. By doing that, you then pull down these additional federal funds. Kit. Oh. Oh, my apologies. Thank you for paying attention.
To kind of follow up on what Mike's saying and maybe tie into this slide loosely, if you remember back on that funding slide, Mike mentioned that part of the challenge was that we've been having to give back most of our premium every year. This amounted to tens of millions of dollars. Last year was $28 million. I think the year before was $36 million. These are all funds that we already had that for the CMS should have been allocated to sick people. We did not have those sick people. Do we know somebody with sick people? Central Health has sick people. So the whole idea with this program is that we're trying to line this up so that we can keep these funds instead of giving it back. And this is, you know, successfully executing so far. But it's just this idea that, remember I said there's two sets of subsidy, one for low income and another one for health and morbidity. So if you're sick, you get funding, like we're on path with this plan to successfully keep more of those dollars for the sick people who would otherwise be uninsured and back on Central Health directly. So I think that's it.
Now it's my turn. As both Mike and Wes have talked about, we did create this strategy where we offered to our MAP members the opportunity to move into Sendero if they so chose to do so. We had a review of our members to make sure that the sort of their health status qualified for them for this program, and then also just their county residence and income. We did open this up to a few of our sliding fee scale population, those members from community care. And all in all, you know, the Board of Managers approved this in late September, so we really had a very short period of time. I mean, this strategy had to go through the open enrollment period, so we had from November 1 through December 15th to get members enrolled. So we used multiple strategies. We had a calling campaign where we called people on Saturdays and after hours. We sent letters to our MAP members. And then we did some home visits. I'm very pleased Carmen had some of her community health workers actually went out and talked to individuals to educate them about this opportunity. Because these individuals were MAP members, this wasn't something we were just going to hand over a list to Sendero and said, here, go outreach to this group. I mean, we felt that it was important, that it was a choice, that we went and explained the opportunity to the members, and then once they agreed that this is something they wanted to learn more about, that they were interested, we then connected them to a Sendero representative, and that's where you can see 96% of the individuals that actually met with a Sendero representative made the decision to choose to enroll in the program. And our total enrollment was 223 members. Now I don't remember who's next.
And this slide, probably the simplest way to say it is that for, our plan this year was to do two things. And one was to reduce the total risk by shrinking the size of the plan. So this was, working with Central Health. We said, hey, this has been getting costly. We're kind of concerned about it. Can we just shrink it down to cover the absolute risk? There are some risks to shrinking a health plan because remember what we said at the beginning, in general, the more people you cover, the more you can spread the risk. But for this, as like a short-term study, we shrank the plan, which was good. That was successful. Additionally, we transferred, just like Kit was saying, that say this was very successful. On a short notice, we transferred 223, I guess I'd classify as high-risk, very sick individuals into full coverage on our plan. By doing so, the actuaries. So this is from 2 independent sets of actuaries. They did a number of scenarios, which, we won't go through all of them, but you can see, depending upon like how many, well, if all the numbers were there, but depending on how many people we enrolled and how many people we enrolled moved over in the program and how sick they were, there were a range of possible outcomes. And we are, within the range of one of the scenarios, one of the biggest group of scenarios in there, where we expect to break even. And this is insurance. The financials usually lag like 3 to 6 months to be really sure. So at this point, there's nothing we can say definitively other than anecdotally, we are very happy that we're being able to provide quality care for these people, because we've got a lot of resources, we have broader networks. A lot of the employees say this has been the most rewarding experience of their careers because we're really getting a chance to match up with the people who need the care the most.
I want to give you a sense about what to expect as the board begins to develop the budget for fiscal year 2020. Our fiscal year it starts October 1, runs through September 30, and the budget process starts first part of summer. These are just a few of the items that, our total budget this year is $258 million. And these are just a few of the items that, broad general categories rather, to describe how we spend those taxpayer dollars that are entrusted to us. And the first one, as you see, is a capital investment in Sendero, but I would also say it's a continuation of the premium assistance program. But I need to be just blunt about where we are right now with Sendero. It's still early in the year yet, and we're not out of the woods by any stretch of the imagination. We only have a couple of months where the claims come in. Right now, you're showing a projection of break even, slightly better. But as we mentioned before, in the Affordable Care Act marketplace, there's a lot of volatility around that. It's not uncommon at all to see a swing of $1 million, $2 million. That's a relatively small swing in the Affordable Care Act marketplace, meaning your results can move around quite a bit. We've seen much larger swings than that, to the tune of double-digit millions. And so while we like to look out as far as we can, we're only as good as the data that we have in the door. And so as we get closer to June, we'll have more claims data, we'll have actuarial opinions, and we'll be able to do a better job of coming back to you and saying, okay, here's how we think things are going to play out. The programs for the patient population and the healthcare services, 2 and 3 are kind of one and the same. 2 describes the names of our programs and the enrollment and eligibility work that we do. We're going to be simplifying. You see MAP Basic, that will take the place of the sliding fee scale, and you'll hear more about that in the coming weeks. We're really excited about that. We think that's a very patient-centric move that's been long overdue. And of course, we're going to continue to be out there on the Affordable Care Act marketplace as open enrollment starts under Michelle's leadership of talking about what options do you have out there. And then there's the healthcare services that we pay for, primary care and specialty care. You remember the diagram that I showed you earlier through the Community Care Collaborative. We fund primary and specialty care for, if you count the medical access program plus the MAP Basic, that's easily over 100,000 people, probably 105,000, 108,000 people that are relying upon us to continue to fund their care, whether they go to community care or to Peoples. Regina, I want credit for having said Peoples twice tonight. And then service expansion. So we talk about the programs that we have to fund healthcare, what they're called, and then there's where we fund healthcare. And this is a big initiative of ours, and you see a map back there about Eastern Travis County. This is about getting out there and putting down temporary facilities in the form of modulars. We have a mobile clinic that we recently purchased that we're going to be rolling out this summer. But it's also longer term, as through gentrification and other displacement and other public policies, quite frankly, that are forcing everybody east. What can we do to be out there to be a part of their community, of their lives? And so it's also about when we say service expansion in Eastern Travis County, it's about being present in the communities with a much more robust presence, whether it's bricks and mortar or programs or community healthcare workers our transportation programs to link people to care. So these are just some of the budget priorities that we'll be bringing back to the Board of Managers as we start the budget process this summer.
Well, welcome. I got to see many of my previous friends, and I made lots of new friends today. And I've had the honor of serving as chair of Central Health for the last 16 months, which has been a great honor to do. It's just a wonderful, the right thing to do is what I tell my board all the time. And on behalf of Manager Musaitif, Manager Jones, Manager Bell, and myself, and the rest of the managers, we can't thank you enough for coming tonight. We know it's a Monday night and y'all are tired, but we need your information on how to continue. So again, thank you so much for coming. In June, Board of Managers from both Sendero and Central Health will evaluate Sendero's business operations and future financial forecasts. Central Health Board of Managers will need to consider future funding needs for Sendero that will allow it to continue. Thank you. Mike.
Yes. So if we can go ahead, let's go to the next slide. I'll take it from here. So you can see the next steps here just in terms of your calendaring. April 24th, we have a Board of Managers meeting where we'll have updates, and these typically come in the form of updates from Wes and his team, and then usually some lively discussion amongst board members about what those results are showing. And this is a really good place to get a lot of information. If you can't make it to the board meeting, don't worry. They're archived on the web if you don't have access to the web, but you do have access to cable TV. We're televised as well. Or, hey, swing by here and we'll hook you up with a computer if you have people that have digital access issues or transportation issues. We'll find some way to hook you into what's being said in these board meetings. We have May 29th, a Board of Managers meeting update. What's significant about May 29th is in insurance company land, you have to file your first quarter financial results with the regulators, in this case the Department of Insurance, by the 1st of May. And so this will give us a chance to take a glimpse into the first quarter. And then in June 19th, we have the Board of Managers meeting. And what's significant about that date is there was a resolution that was passed by our board, as many of you all know that were here at the September meeting, which said, let's look and see where we are in June, and let's talk about the viability of the business plans going forward. And these are business plans that Sendero will put together, in light of what we know about the ACA marketplace. So those are key dates that, we'll hope that you'll jot those down somewhere. If you don't have something to write with, we'll give you something to write with. Again, we'll put this information out there through social media, on the website, and other ways of communication. With that.
So Mike, we're going to open it up now for questions. So if you have any questions you'd like to ask, just raise your hand. I'm going to bring the microphone to you because we are broadcasting this or live streaming this. We want to make sure all the audio is captured. So if you wouldn't mind stating your name and then asking your question.
Actually, could we take this first question? I'm already cutting Frank off, but yeah, we promise. Go ahead, Frank, ask your question, then we'll take this first one.
So Mike, you mentioned competing funding needs
right.
for the budget process, and then Dr. Zamota mentioned future funding needs as well, and looking at business operations. What sort of criteria are you going to be using to gauge that? Are you solely just looking at dollars out? Are you looking at leveraging? Are you looking at people served? I mean, I just want to get a sense of how comprehensive a view you'll be looking at each of these competing needs. Because, for example, when you look at community care, I just did a quick jot. For those 11 years that Sendero's been in operation, I think you mentioned $108 million capital invested. Mm-hmm. For community care, it's $314 million. I'm not speaking to the impact of those dollars, but just simply dollars out.
Right.
When you look at the medical school, $210 million versus $108 million for Sendero. When you look at, again, no value judgment on, the efficacy of that. Yeah. And in the IGT, you invest $1 or you send up $1, you get $2.40 back, about $2.40. That's the leveraging. Mm-hmm. With Sendero, you would get 50% more. So $1, you get $3.40 back. Again, right. Just jotting some notes. So I'm really interested in how, when you get into this process, aside from listening to the citizens and patients and the people being served, which is a qualitative kind of dimension of evaluation, but you also look at kind of the fiscal impact and the benefits for the dollars being spent.
Right.
My question is, are you going to kind of try to incorporate some of that at least in your evaluation?
Right. And
thanks.
And it's not that we're kind of going to do it, we are going to do it. Everything's changing on the federal landscape in terms of how all of the funding streams are put together. And what we're doing right now, and we're going through this exercise with all of our partners, including Ascension Seton, is looking at what are the likely funding streams that are going to be available and what do we do to leverage these tax dollars. One of the slides that we didn't put up here is that when you look at urban healthcare districts, Central Health is has one of the lowest tax rates, but we're also serving 1 in 7. I know the little movie thing said 1 in 10, but it's 1 in 7 of every Travis County residents. And the reason we have such an effective business model is because not only do we leverage funds, but also we have partnerships that can bring things to the table that we can't by ourselves. And so the answer to that is, from a fiscal standpoint, yes, it is an all-out leveraging exercise, because without that, we would have to raise tax rates exponentially. And that's hard on folks that are struggling to hang on to their house or paying rent, because that all gets passed on to everybody pays property taxes. Sir, you had a question. Could you, Wes, you were going to take that one? You might want to restate the question.
There you go. I kind of remember it was, excuse me, okay. So I'll try to answer it, split it up. So maybe part of your question is the value of insurance to someone. And I think, undoubtedly, if you don't have insurance, you are pretty much at the mercy of the providers and the facilities to charge what they want. The way healthcare has evolved, it pretty much, there's I guess you could say, a standard bill of charges or fee schedules. And yes, it's traditional for insurance companies to negotiate pretty substantial discounts as a volume purchaser with these. And as an individual, it goes back to that. It's really hard to say. I think maybe the easiest way to characterize it is that, in my experience, a lot of times you'll get billed to the extent you can pay, pretty much. So for insurance, yes, everybody complains about the cost of insurance. We feel horrible about it, like we wish we could do more to get premiums lower. We're a nonprofit. We're not taking money out of the system, unlike other plans. Like, everything is staying right here, and we're just trying to make the most of it. But it is a challenge. However, even at those costs, there's definitely still net value, and even the actuaries would back that up, that you're better off with insurance than without it. I think that was kind of the...
I think my question was, you had $475 million in payments delivered or something,
yeah,
which is some good bragging rights. And there's another, I don't know, 400 million, an unknown number of braggable rights in the contract adjustments, if you could find that number somewhere.
If, I guess the part of this is that it is confidential. We worked hard. A lot of providers worked hard with us, and we're happy that a lot of them have been working with us. I guess you could say that we definitely get substantial discounts. That number would be multiples of that 400 million, without insurance. Yeah.
Any other questions? Anybody? Please.
Let's go back to this.
Okay.
Just to do some rough math, let's just say that you have basic primary care, but then you have one inpatient admission. Easily that's 6 figures, but let's just knock that in half for grins and say $50,000. If the policy that you have is a 70-30, then just ballparking it back, Aggie-friendly, back of the envelope math, if you took 70% of that $50,000, that's, what insurance would pay, but then insurance comes in and contracts an even lower rate. And so it's 70% of that lower rate. So let's say it went from $50,000 to $30,000 as a result of what the insurance company did. then that value is 70% of $30,000 is what, $21,000. So that's the value that you're getting for the premium. But just to put it into real life terms of what it means to you, so what could have been a $50,000 bill brought it down to 30, covered 21,000 of it, and then you got the balance, which is going to be $9,000. That's a lot better than going into, you can work through a $9,000 debt a lot easier than you can a $50,000 debt.
Do you have another question? Okay, I'll go over here. And do you mind stating your name first?
My name is Andy Manchala. I just want to ask about the risk. I see a lot of dependency on Affordable Care Act. What if federal government drops ACA?
Wes, do you want
Sure. So that's been an ongoing debate and concern, and there's two parts. I think the easy way to say is I would not place bets on anything. I have no idea what's going to happen. The good thing is that even when you look historically at all the attempts to repeal it, one, they were unsuccessful. I think the number is close to 70 attempts to repeal it so far. And two, even with those attempts to repeal it, they did follow the rule in the sense of implementation. So it's not that insurance would stop tomorrow, but that it would stop for the next year, for the coming year, so everybody would have time to adjust and we would not be, it's true. If we did not expect, for some reason, it's like, no, we would not make plans to go forward. So we don't have to really finalize our commitment until September for the following year.
So just to reiterate what Wes said, if there was a change on the Affordable Care Act, it wouldn't be implemented from one day to the next. There would definitely be a transition period, so you wouldn't see anybody lose coverage from one day to the next. But whether it's a repeal, a replace, and invalidate the law, Central Health is here and committed to our residents. So we have several local programs, whether it's Ideal Care, through the health insurance marketplace, our local programs, MAP Basic, and then we have sliding fee scale plans with our safety net programs. So our first priority is our residents, and so no one in Travis County should go without health care, because regardless of what the outcome is, we are here to walk our residents through every step of the way.
I actually want to ask a follow-up question to that, and this hasn't come up yet, and maybe it's for you, Kit. But when medical access program members were offered the chance to switch to Sendero, were they told what would happen next year or the year after if for some reason Sendero weren't to move forward? Can you talk a little bit about that?
Yes. So.
And where they would go?
Yes, members were told if this program did not continue into 2020, that's so strange to say 2020, that as long as they were still Travis County residents and met our income criteria, they could come back to the medical access program. We did put the constraint on this year, if a MAP member made the decision to move to Sendero, that they were committed to that plan for the full year, that they couldn't midway through the year make the decision to come back to MAP. I'm happy to say nobody has contacted us and asked us to do that, but we were clear with folks in the process that it was a year-long commitment, but that after that year, that they could have the decision to come back to the program, or if the program didn't continue and they were still eligible, they would be re-enrolled in MAP.
Okay.
Hi, my name is Carmen, and my question ties into the last couple of questions. So I have two parts to my question. What you said, it's the services that a patient can currently access with Sendero are really different than the services that a patient could access with MAP or the sliding fee scale or MAP Basic. So there's going to be patients that are accessing services like dialysis that they might not be able to access if they come back to MAP. So I know that it sounds like you guys won't have a definitive answer on the viability of the program until June, but is there any planning going on now, or were the planning starting June in case it does turn out to be the worst case scenario that this service or program won't be available the next year?
I'm thinking it's more a central health question.
Yeah.
I don't want to.
So we've had these internal discussions even before this year, knowing that the strategy was going to move forward. You know, what happens if, and so, you know, think worst case scenario, and it is important. In fact, we've been, you know, this is a point that the Board of Managers emphasizes, which is we want people to be taken care of, regardless of what happens, and that's what Michelle was pointing to. There have been some discussions around, because of the richness of the benefits in Sendero. First of all, you have a little bit broader network. You got ARC in there as a primary care provider, I believe. Is that right? I'm looking for a head nod. Okay, so you've got a broader network, but then something like dialysis there has to be some type of continuum of care, and if somebody did have to be transitioned to another health plan and they were currently paying their own premiums, that's one thing, but what about these individuals that are not paying their own premiums? And there's a number of different things we could do. As pointed out, they could certainly return to MAP, but we don't want their care disrupted. And so it could be that, and again, I don't want to get out ahead of the Board of Managers, but we're paying premium assistance already. That's a program that was in place even before this program with Ham and Sims here in Travis County, that if there's other insurance companies on the marketplace, then those premium assistance funds could be paid to help take care of those individuals. Or we could set up other types of programs through the medical access program or MAP Basic to also take care of those individuals. But those conversations, no, they were begun last year, knowing we have to have a game plan if something happens.
Mike, this is a question for either you or Dr. Bell. You may want to weigh in. Dr. Bell is on the board of Sendero and Central Health. But can you talk a little bit about the decision matrix that will begin in June? Is this a Central Health decision about whether Sendero continues and moves forward? Is this a Sendero decision, a combination of both? Could somebody take that question?
Take a stab at it first.
Thanks, Ted. It's a combination of both. Central Health is our parent company. And so if we do not have the capital to be able to go forward, we're unable to go forward. However, if we as a Sendero board can look at operational strategies that can either lessen the amount of capital that's needed or actually take care of any capital needs that we need, we would formulate those strategies and provide them to the Central Health Board to analyze and let us know whether or not they would support our strategies. Again, our financial backing is from Central Health. So without that and without their support, it's hard for Sendero to continue. We have operational decisions that we make, but the capital decisions are for the Central Health Board to make. Mike?
I'll add 2 points to that. There's another you mentioned matrix. There's another party that's not in the room right now, and that's the insurance regulator. So Sendero, being a health insurance plan, they're regulated by the Department of Insurance. And the Department of Insurance, they have certain capital requirements, and there's a score that you have to hit as an insurance company. And if there's sufficient funds that come in through these business operations to be able to add some to surplus, and you can get that score to where it needs to be, and the regulators are good, then okay. But that's, again, it's still early yet, but that's part of this matrix is, what are the insurance regulators saying?
Questions, anybody? Please just raise your hand.
Frank in the back.
I'll circle back to you, Frank.
Thank you. My name is Morgan Woodhoff. Do you have a slide entitled Fall 2018 Actuarial Projections? It's got a graph and an x-axis, and I'm completely fogged as to what it's trying to tell me. If you can explain it in 90 seconds or less, I'd appreciate it. What's the x-axis, and why is there a zigzaggy line? What makes the line?
Let me get there. Here we go. No.
Oh.
Stand by.
Not that one.
Yeah, I know. Here, Michael, we can do it.
So remember, there were two sets of actuaries, and actuaries are kind of like the CPAs of the insurance world. They look at your claims experience, offer up opinions, and we had asked them separately, Central Health and Sendero, each asked our own actuaries to look at our historical data, look at the plans, the strategy, and give us some range of scenarios, and how those scenarios would impact. And the levers for each scenario were basically the base membership. In this scenario, so the actuary said, okay, we'll say there's 15,000 members, base members, 200 CHAP program members with an average relative risk of 15. That would put us here in net income. And, in all the different scenarios, this one was the one we were closest to, in that we have just over 14,000 members, just over 200 members. The risk score is unknown, but, 8, 10, 15, 20 times risk or something like that. So that's basically it's just saying that, the actuaries forecast a range of outcomes, almost all of which were break even or better, and we are within those range of projections based on what we have.
Thanks.
I wanted to thank the Central Health Board of Managers for making a tough decision last time and keeping an open mind and listening to the public and patients and members, and considering all the input they got back then. And I'm hoping that this process continues in this year, and that the public hearing or public testimony can be done at an earlier point in time. And I'm appreciative of the staff arranging this meeting. The question for Wes is, I'm a little concerned about the rates, and I know that there was a bump up the rates, and some of that was to probably fund or refund the capital that maybe Central Health was providing you in the rate structure. I'm speculating, I don't know. But I know it probably affects those members that are really the profile of Central Health's service population, very poor and needy. And did you sense any impacts from the population because of the rates that had gone up so high for Sendero?
Two parts. The first is, as I think we mentioned earlier, the rate setting is a painful process. We do everything. We fully recognize, the affordability issue, and are always challenged to try and keep that as low as we can. Right now, our premiums are in line. There's differences in network and benefits and so forth, but are in line with the other plans. We definitely think we offer more value. Going forward, we would like to be in a position where, ideally this program will execute successfully so we could expand it. That would stabilize our financials, and then we could offer lower premiums to cover more of the population. That's the ideal scenario.
Thank you. Jim Rodriguez with Tex Health. You've got 15,000 up there. What are the possibilities of increasing that? Because wouldn't that help solidify your financial position if you have non-MAP members who are actually bringing in more income, and theoretically you're making profit from that?
Yes, real roughly. So the challenge in past years, remember, is that we had more members, but we were giving back most of the premium, a big chunk of the premium anyways. So, but with this program, in theory, we can enroll more members and balance it out, keep all those funds locally, and like you said, help support the system.
Anybody else have any questions or even thoughts that you might want to share? I would like to add that we're also going to capture the notes and questions from this meeting and share that with you via email. So when you signed in, if you didn't leave us your email address, please do that. Or if you're already on our mailing list, we'll make sure that you get a recap of tonight's meeting.
Hi, I'm just wondering, how do you what exactly is your capital funding origin source? Like, how is that, what is that capital funding that you like mentioned? Is it federal tax dollars or is it state? How does that come into Sendero and Central Health?
Good question. So we're funded by property tax dollars, and this year we're on target to collect 198 million, 196 million in property tax dollars. And so the Board of Managers through the budget process decides how do you allocate those funds. And right now, Sendero is funded by those property tax dollars in the form of capital contributions to Sendero, or we also have what we call debentures, which are a form of debt that are loaned to Sendero. Now, as well, I'll turn it over to Wes. In your premiums, do you price for capital contribution?
No, other than some surplus retention.
So it's strictly from us. Now, the whole point of that business plan that we talked about is, and somebody mentioned it earlier, Frank, I think it might have been you, but talking about the federal match, because of the way that federal risk pool works, you can bring down a lot more funds. It's another way to leverage those federal dollars, which even if you don't theoretically get a check paid back to you, if you have to pay out a lot less or none at all, then even better. So that's part of the overall funding strategy for Sendero. Oh, I'm sorry. And we have two other board members over here. Sorry. We have Manager Jones and Manager Masada.
Well, thank you all. Yes, I'm not familiar. Well, again, thank you for being here this evening. This is quite helpful. I just want you, as a board member, and I do not speak of all board members, but I can assure you this, we always put our community first and foremost at the heart and center of every decision we make, and Sendero is one of those really difficult decisions, and we will assure you we will do all our best to do what is right for our community. Thank you.
Sorry, Eric. So just running through some of the math in my head, we moved over about 223 MAP members to Sendero. I think we mentioned earlier that the expected outlay for premium assistance was approximately $3.6 million for this financial year. With the transition of the MAP members to Sendero, what is the expected outlay due to exposure to hospital-based services as well as emergency department utilization relative to their current MAP utilization and cost exposure?
Well, two things. Yeah, I don't know how deep we want to get, but you know.
Hang on a second. Let's interpret that question.
Yeah. It's kind of a.
Sorry. So ultimately, it's what is the expected cost exposure or financial outlay as a result of the transition from the medical access program and our partnership with Seton and the utilization and financial resource that we're able to maximize through that partnership, and then the offset and the additional IGT that we pull down with our partnership with Sendero, but recognizing now that we may be financially compensating for ER and hospital-based services and procedures.
So if this is a lot. So if you look at it from the MAP side, you know, you've kind of, I hate to say it this way, but in a sense, in some degree, you've gained capacity because you've taken some very sick people. Without a doubt, the cost of services or the value of services for those members is worth way more than the cost of premiums. So Central Health comes out ahead. For Seton, however you want to frame it, or the facility partners, not just Seton, but it's community care, it's everybody. In theory, well, no, it's not a theory. In practice, already they're coming out ahead because they're getting paid at commercial rates with the dollars we're bringing down. If you say in terms of impact of utilization, I'd say, well, the core utilization already existed. These are people that were, very sick and being cared for. There is an increase in utilization because these people are able to access more services in the broader network. And we've seen, I think it was easily a third, half so far, have gone outside of the base network to access, specialty care things. So it's, we're trying to, it's hard to believe, but in a sense, we're trying to frame this as it should be a win-win situation all around because you're retaining more local funding for the same care that's already, the same and better care that's already taking place.
That's a great question. Let me just, again, do a back of the envelope. But if you were to take that $3.6 million and run it through the IGT process, you know, you're pulling down $1.20 for that. That's going to be $4.3 million that you would pull down for that 3.6. Because of the risk pool match, I think it is, I would be conservative by saying $5 for every dollar. I think it's probably slightly higher, but let's just be conservative about it and say $5. So 5 times 3.6 is 18. So for $3.6 million, it's a difference of $18 million versus 4 and some change. It's a good question.
Hey there, my name's Alyssa. I'm with KXAN News. Ted said I could ask a question. So I think this is for the Sendero folks. And forgive me if this is something you touched on before. I just want to make sure I'm clear about what the answer is. For moving those 223 people from MAP over into Sendero, how has that gone so far? Has it had the results that you've expected? Can you give the community kind of an update about how that's gone as a strategy?
So if we're saying operationally, I don't want to, I mean, to build on what Kit said, but basically there's a handoff, and this has been, this goes back to what I said earlier. I think for the staff, they all said it's been a very rewarding experience because our staff started working with the members the minute they knew they were going to enroll to let them know, you know, here's the expanded benefits, here's the services you can get. So operationally, that part has been all very successful. There's a lot, definitely significant amount of care that have been provided so far. That's been successful. The part that's unknown, kind of touch on Mike's numbers, you know, it kind of goes back to this graph. You know, there's a wide range, you know, of outcomes depending upon, you know, the care that these people need and how sick CMS evaluates them to be. You know, there's a lot of factors playing out. And that's the piece that, you know, hopefully over the next months we'll have enough of a grip on so that we can let Central Health make a decision about continuing that CHAP portion going forward.
Got it. And then as far as the ACA risk funding that Sendero then becomes eligible for as a result of taking on those additional clients, has that all been working as expected?
That's the part that won't play out till throughout the year. The first we get from the actuaries will be in June sometime. But there's no question that people are sick, and that is one of the qualifications. So, you know, we're confident, hopeful that things will play out as the actuaries expected.
Thank you.
Did somebody up here, did you have another question? And I'll come back to you.
On your sliding scale, do you receive a patient population of like underinsured? And I've seen in literature where it's called like they can be classified as like the middle class. Do you, as your organization, see that, and are they applied to MAP and Sendero? Thank you.
So when you're talking about the sliding fee scale population, each of the clinic systems have a sliding fee scale enrollment process, and that could be for folks that are underinsured or have some insurance but a high deductible or copay.
Okay.
When you're talking about what Central Health funds, we only fund the care for the uninsured. So it would be folks that have no insurance that are accessing the sliding fee scale or MAP Basic.
All right, thank you.
Hi. This is not so much a question as a comment. You know, we're talking about the wins for the different organizations involved, but I do have to say that this is a win for the patients that we're taking care of, in the services that they can access, in the care that they can receive. And I think everybody in the room understands the importance of hopefully making this program successful.
Carmen, why don't you share with people what you do with the organization, because I don't think people know the insight that you have.
So I work for community care, and I'm an RN, and I'm the manager for the care management teams within community care. So I've been in that role for about a year. I've been a nurse for about 12 years and an RN care manager for a little bit over 2-3 years. So it's close to my heart.
Thank you for what you do. Anybody else have any questions? Raise your hand if you have something else you'd like to ask. Anybody? Good. Yes, please.
Yeah, it's probably to Mike or perhaps Wes. Back in September, when I heard that there was plans to shut down Sendero, and there was some mention of the ACA going away at the time, despite multiple efforts that were unsuccessful. It seemed to me that that would be the best time to keep a community-based nonprofit available to the community when there was so much uncertainty as to what's going to happen at the federal level. It was just an observation I made. It's like now more than ever you would want to keep an asset to have the flexibility should Donald Trump prevail and eliminate the ACA, Donald Trump and the Republicans, which isn't likely with the House the way it is. But again, I just, is that accurate that there's a, you know, it's still an insurance company. There was insurance companies before we had the ACA, and it just seems to me that, you know, it's adaptable however we want to create it as a community. And is that a fair assumption?
Is what a fair assumption?
That it would be adaptable and, you know, if ACA doesn't exist,
Right.
it still exists.
Right. Well, I think that's a hypothetical that would be difficult for any management team or insurance board to answer. You know, do we go back to the days of old school indemnity insurance, for instance? And I think understanding what the insurance markets would look like if the ACA were to go away, there's a lot of treatises and graduate studies out there, and it's just hard to pick which one might be right. I would say that there's always going to be a place when you're talking about risk, especially health risk, a catastrophic illness, a disease, that insurance is always going to play a part in that. I mean, it's just a fabric of you know, where we are right now in time and place. To what extent, I don't know. It would not surprise me at all if you started seeing more indemnity products come back in the future. I think with respect to what you were saying about, you know, doesn't it seem like if it looks like something's going to go away, that this is the time to keep an insurance company going. The challenge that we all have, and we're all in the same enterprise here. There's no we, them, and us. We're all part of the same enterprise. The challenge is being able to manage the volatility. And when the volatility swings $1 million, it's okay. But when it swings 20 million, 30 million, you can't really budget for that from one year to the next. And there's a lot of insurance companies out there that if you were to go to them and say, you know what, we have a risk corridor and it's going to be, you know, it might be plus 7 million, but only a minus 2 million. They'd be like, yeah, we'll take that risk. But if you were to go to that same insurance company and say, we can give you plus 50 million, but you might lose 20 million, they won't take that risk, even though the upside is potentially 50 million, because you're looking for a narrow band that you can budget for and reserve for. And the challenge with any insurance company, whether you're talking about a community benefit plan like Sendero, or you're talking about, you know, one of the big larger ones like Blue and United and all that, is you need to have the sustainability to be able to be there year in, year out. Because how many of you have lost, you've gotten one of those letters in the mail, and the company is staying in the market, let's say, because they're going to go write it in another state, but they've just decided to pull out of Texas. I mean, you know what? You probably know people that have been through that. That's a tough thing. And so you want to make sure you can be there for people year in, year out. But your points are well taken.
Any other questions? So I think we're going to give you some time back tonight. It's about 20 till 8. But I wanted to let you know that our staff will be here to answer questions one-on-one if you have them. And again, we also have some note cards. You can leave a question in writing. And we will be following up with you with an email about what you heard tonight. And you're always welcome and encouraged to email us with more questions, and we will answer them as quickly as possible. And instead of thanking our panel, I think we want to thank you guys for showing up tonight and asking great questions and caring. So thank you for being here. And if you haven't had a sandwich, please take one home to your somebody, because else we'll be putting them in the refrigerator back. So thank you again for being here.